2. Hey everyone, and welcome back to the channel. Today, we're diving into one of the most requested, most tested, and most clinically relevant topics I've ever covered: diabetes pharmacology. I know, it seems like a huge, intimidating subject, but I promise, by the end of this video, you'll have a clear, organized framework that makes it all click. The easiest way to approach these drugs, especially for your board exams like USMLE or COMLEX, is to split them into two main categories: drugs for type 1 diabetes and drugs for type 2 diabetes. Now, in the real world, there's some overlap, but for test day, the distinction is usually very straightforward. Type 1 diabetes is all about insulin. Type 2 diabetes is primarily managed with oral anti-hyperglycemic agents. It's that simple. Let's start with insulin. It might seem complicated with all the different names, but you only need to know three key things for each one: the name, its peak time, and its duration of action. That's it. First up, we have the rapid-acting insulins. Think Lispro, Aspart, and Glulisine. A good way to remember them is that you don't want a lag in your insulin action. So you use Lispro, Aspart, and Glulisine. These guys act fast. They peak in about 1 to 1.5 hours and last for about 3 to 4 hours. This makes them perfect for covering meals, what we call prandial insulin, and for correcting high blood sugar readings. So, when a patient is about to eat, this is the type of insulin they'll likely take. Next is short-acting insulin. This is just good old regular insulin. Regular insulin is a bit slower than the rapid-acting ones. Peaks at around 2.5 hours, and its effects last for about 4 to 6 hours. Because of this timing, it's not as ideal for mealtime coverage as the rapid-acting insulins, but you'll still see it used, especially in 4 drips for conditions like DKA. Moving on to intermediate-acting insulin, the main one you need to know is NPH insulin. NPH stands for neutral protomine, Hagedorn, but nobody calls it that. Just remember NPH. It has a much longer profile, peaking around 8 hours and lasting for 10 to 16 hours. Screw. You can think of it as bridging the gap between mealtime insulin and the long-acting basal insulins. It's often given twice a day to provide some background coverage. Finally, we have the long-acting insulins. These are your basal insulins, the ones that mimic the pancreas's constant, low-level background insulin secretion. The big names here are glargine and detamere. The key feature of these insulins is that they have no true peak. They provide a steady, flat level of insulin for about 24 hours. So, a patient might take 1 shot of glargine or detamere a day to cover their basal needs, and then use rapid-acting insulin before meals. It's all about recreating what a healthy pancreas does naturally. So, to recap insulin super quick: rapid-acting like Lispro and Aspart for meals, short-acting regular insulin, intermediate-acting NPH, and long-acting glargine and detamere for 24-hour basal coverage. Master the names, peaks, and durations, and you've got insulin down. Alright, now that we've covered insulin, let's shift gears to the main event: the oral medications for type 2 diabetes. This is where the bulk of the pharmacology questions will come from. The cornerstone, the first-line agent, the one you absolutely have to know inside and out, is metformin. Metformin is in a class of its own called big WNEDs. Its primary mechanism is decreasing hepatic gluconeogenesis. That means it tells the liver to stop producing so much sugar. It also increases the uptake of glucose into peripheral tissues like muscle. So, the net effect is a lower blood glucose level without directly stimulating insulin release, which is great because it doesn't typically cause hypoglycemia on its own. But the most high-yield fact about metformin is its major side effect: lactic acidosis. This is a rare but serious complication, and the risk is highest in patients with renal insufficiency. This is why metformin is almost always held in hospitalized patients, especially if they're getting IV contrast for a CT scan, as the contrast can be tough on the kidneys. Next up, let's talk about the drugs that stimulate the pancreas to release more insulin. We have 2 classes that do this: the sulfonylureas and the meglitinides. Sulfonylureas are the older drugs, with names that usually end in ide-like glipizide, glyburide, and glypiride. Meglitinides end in glinide-like repaglinide. Both classes work by closing potassium channels on pancreatic beta cells, which causes the cells to depolarize and release insulin. Because they directly increase insulin levels. Their main side effect is predictable: hypoglycemia. they can also cause weight gain. Now, for some of the newer, more complex agents, let's start with the incretin pathway. We have DPP for inhibitors and GLP-1 agonists. This sounds complicated, but it's not. GLP-1 is a natural hormone that tells your pancreas to release insulin and tells your liver to stop making glucagon after you eat. DPP-4 is an enzyme that breaks down GLP-1. So, if you inhibit DPP-4, you get more GLP-1, which means more insulin and less glucagon. The DPP-4 inhibitors are easy to spot because their names end in gliptin, like sitagliptin and saxagliptin. They are oral pills and are generally the other way to target this pathway is to just give a drug that acts like GLP-1. These are the GLP-1 agonists, and their names end in tide, like exenatide and liraglutide. These are injectable medications, not oral. They are very effective and have the added benefit of promoting weight loss. However, the big side effect to remember for exams is pancreatitis. If a patient on a GLP-1 agonist comes in with severe abdominal pain, you have to consider. Let's move to a completely different mechanism, the kidneys. This is where the SGLT2 inhibitors come in. SGLT2 is a transporter in the proximal tubule of the kidney that reabsorbs glucose from the urine back into the blood. These drugs, which end in flozin like canagliflozin and empagliflozin, block this transporter. So, instead of glucose being reabsorbed, it gets peed out. It's a pretty clever way to lower blood sugar. The main side effects are a direct result of this mechanism. All that sugar in the urine can lead to urinary tract infections and yeast infections. But these drugs also have some amazing cardiovascular and renal protective benefits, which is why they are becoming so popular. We're almost there. Just a couple more classes to cover. First are the alpha-glucosidase inhibitors, like acarbose. These drugs work in the intestines. They block the enzymes that break down complex carbohydrates into simple sugars. So, sugar absorption from your gut is slowed down. The downside is that all those undigested carbs end up getting fermented by bacteria in your colon, which leads to the classic side effects of gas, bloating, and diarrhea. They aren't used as much because of these side effects. Next, we have the thiazolidinediones, or TZDs. Their names end in glitazone, like pure glitazone. These drugs are insulin sensitizers. They work by activating a receptor called PPA-R-gamma, which makes the body's cells more responsive to insulin. The big high-yield adverse effects you need to associate with TZDs are fluid retention, which can worsen or cause congestive heart failure, and an increased risk of bone fractures. So, you'd be very cautious using these in a patient with a history of heart failure. Finally, there's a minor player called amylin analogs, like pramlintide. Amylin is another hormone released with insulin that helps control blood sugar. Pramlintide is an injectable that's used along with insulin, but its main side effect is, you guessed it, hypoglycemia, because it's used with insulin. And that's the whole landscape. I know it was a lot of information, but if you focus on understanding the drug class, its core mechanism, and one or two key side effects for each, you will absolutely dominate diabetes pharmacology questions. These knowledge isn't just for acing your exams. It's fundamental to safely and effectively treating patients in real-life clinical practice. Thank you so much for watching. I hope this breakdown was helpful. If you found value in this video, please give it a thumbs up and consider subscribing for more high-yield medical content. Let me know in the comments if you have any questions or what topic you'd like to see next. See you in the next video.